To talk about SIBO, small intestinal bacterial overgrowth. This is something I think you're all a bit more comfortable with and may actually do testing. We're hoping you use Genova's test, or we launched SIBO. It's completely available at this point. So we've offered our SIBO test in the United States for a very long time. It's one of our big flagships, and so we love this test. It was recently completely redone and updated, which is what we're going to touch on here, and we're going to show you why ours is the best. But with that, we're going to talk about SIBO a little bit as well. This may be some review for a lot of you, but let's just go through it anyway. So hopefully by the end of this, we'll be able to just overview SIBO. We'll learn when to consider testing for SIBO. And again, some of this may just be redundant for you. We're going to review our test in detail, which is the best test there. And we're going to talk about treatment of SIBO, give some cases. And then we're going to talk about other tests that may kind of interact with someone with SIBO or in someone in whom you suspect has SIBO. So what is SIBO? We know that this is small intestinal bacterial overgrowth. There's too much bacteria in the small intestine. And, you know, it really isn't an infection per se. It's a real estate issue. Your large intestine has a lot of bacteria. The small intestine, not so much. This is a real estate problem. Bacteria's in the wrong place. And when that happens, when you eat food, it starts to digest and make gases and make you feel really bad and miserable. And it's really just bacteria's in the wrong place. So if you can look at this slide, which we love, here's the stomach, which is pretty acidic. There's hydrochloric acid there, not a happy place for bacteria to live, though some do. Lactobacillus can live up there, some of it. Look at the small intestine. There's a very small amount of bacteria that actually can live in the small intestine. And you see where all of this bacteria lives in the large intestine. So there are reasons for that, like we just talked about. There's the migrating motor complex, which moves things forward. There's acid in the stomach. There's enzymes, and there's things that make it an unhappy place for bacteria higher up. The problem is a lot of these things can be compromised, and so bacteria starts to make its way up, and that's what we call SIBO. So ways that your body can prevent overgrowth of bacteria. Again, we just talked about this. Gastric acid, hydrochloric acid, pancreatic and biliary secretions, peristalsis and the migrating motor complex. So in essence, you know, there are specific mechanical contractions that happen to push juices and things forward. And this is something that is happening all the time. If you can consider if there's a problem with things moving forward, things get static, and that's where bacteria starts to make its way up. The ileocecal valve, which separates your large intestine from your small intestine. So if you have a problem with the ileocecal valve, bacteria is just going to start to make its way up. Your body gave you a valve to stop that reflux of colonic bacteria back up into the small intestine. The compromise of any of these processes can lead to the development of SIBO. Yes, yes, and yes, and yes. We're going to address that several times in this talk. But I think the important part is these are all the ways your body created so that you don't get SIBO. Anytime you mess with any of these, this is what happens. And in that case, he asked about PPIs, proton pump inhibitors. Anything that decreases your gastric acid is going to set you up for SIBO. So which patients would cause you to think about SIBO testing? It's a list of symptoms. It's kind of like when we talked about the hormones, you know, fluctuating hormones. These are really vague. They can fit a lot of different things. We're talking about bloating, gas, cramps, diarrhea, constipation, nausea, heartburn. Pretty vague. These are just, you know, usually people have symptoms like this, and you start out with something like the GI effects, which is super comprehensive. So these kind of overlap with someone in whom I'd get a GI effects. Steatorrhea, nutrient deficiencies, but this is interesting, nutrient deficiencies. The difference here is you eat food, it's broken down. Most of your nutrients are broken down and reabsorbed by the time they leave the small intestine. So if there's a problem in your small intestine, you can start to get nutrient deficiency. So isn't it interesting to think backwards? But if you have someone with just a recurrent nutrient deficiency that you're chasing your tail on, you can backdoor into that and think, is there something going on in the small intestine here? Fat-soluble vitamins, iron, B12, very common in SIBO patients. And it's funny when you ask patients about GI symptoms, they'll say, no, I'm fine. But if you ask them, how often do you go to the bathroom? You be very specific about this. They'll say, oh, once every 2 days, not understanding that that's actually constipation and abnormal because it's their normal. So when you ask these patients about some of these symptoms, sometimes you got to get pretty specific, just as a side note. I'm sure you all know that. There are a lot of conditions that are associated with SIBO, and these might be somewhat intuitive. Functional motility disorders, anything that slows down that migrating motor complex. That is developed to push things through and fluids push things through. If that's compromised, clearly these people have a higher prevalence of SIBO. Neuromuscular diseases, again, it's the muscle contraction of anything. People who have all kinds of neurologic diseases can sometimes manifest SIBO without you even thinking about it. Inflammatory bowel disease, pancreatic disease, celiac disease. Anytime you have a patient that you're going to be putting them on intermittent antibiotics, or you have patients who have inflammatory bowel disease, the whole microbiome is so in flux. There's a lot going on there. Always think about SIBO in the back of your mind for those patients as well. Hypothyroidism. This came up earlier. We discussed this. Very high prevalence of hypothyroidism for a lot of reasons. There's constipation, there's slowing. Thyroid disease in and of itself is highly associated with as well. Liver disease, diabetes. And I would say that you think diabetes, but think about diabetes from this perspective. There's a lot of neuropathy with diabetes, right? Some of that neuropathy and problems with nerves actually can affect things like this peristalsis we're talking about. Additionally, add a lot of sugar on a place where bacteria like to live. I mean, it's a party. So we think about all of these other things. There's many other conditions that are associated with SIBO, and it all comes back to how are they affecting the ways that your body created to prevent it. Pretty common. And here's some just stats that you can pull. Hypothyroidism, 54% of patients with hypothyroidism have SIBO. That's interesting, isn't it? And look at this with chronic fatigue syndrome and IBS. And it always comes back to that place of the gut-brain axis, right? It always comes back to that place, how important the microbiome is. You all know this by now. This is a bidirectional axis with dysbiosis or problems in your GI tract affecting your brain and neurotransmitters and vice versa. So there's a lot of different conditions that are associated with SIBO for that reason. Again, I think we're kind of beating a dead horse here, but the risk factors for developing mechanical stasis, gastroparesis, medications, patients on chronic pain medications. You're slowing everything down. These people are set up. Additionally, there are specific structural abnormalities. We talked about that ileocecal valve. Sometimes patients get colectomies. And for whatever reason, whether it's IBD, things are resected. And most conventional surgeons in their minds don't think about the reflux of colonic bacteria up into the small intestine. It's kind of not where their mind goes. They see something bad, we cut it out. We deal with that chronic bloated patient afterward, and we're trying to figure it out. Irritable bowel syndrome, again, it comes down to the microbiome. Some of the irritable bowel syndrome itself, it's a change in dysbiosis. Sometimes you get constipation just based on that, which can also affect the ability of bacteria to come back up. Similarly with hypothyroidism. Diabetes we just talked about. As you get older, things slow down as you get older, quite similarly. Any of these other specific dysfunctions. Another one that you think about is immunodeficiency states. You think that if you're unable to keep any bacteria in check, doesn't it make sense that they may overgrow? Hypochlorhydria. Again, speaking of elderly patients, as you get older, there's a very high prevalence of hypochlorhydria. Body just stops making hydrochloric acid. Additionally, a lot of these are on proton pump inhibitors. Let's make it even worse. Ta-da. Any type of GI infection. Again, you're altering the microbiome. You're altering the pattern of bacteria in the gut. So now we know who's at risk for SIBO. What happens when that bacteria gets up there? And this is interesting. If you look at this slide, you see all these microvilli, which are important to absorb all your nutrients in your food, right? This is where all that area happens. So the Small intestine and all of its amazingness has all of this surface area to increase the absorption of all your nutrients. At IFM, they talk about taking the small intestine with all of its microvilli and spreading it out. They say that one person's small intestine may be as big as a tennis court. There's so much surface area there to try to get as much absorption of nutrients as possible. If bacteria make its way up into the small intestine where they don't belong, they start to blunt the microvilli. They're taking over the spots. They're blunting all of this. They're causing inflammation. They're thinning what's happening with all that absorption of nutrients. Super important. The gold standard for testing in SIBO, the gold standard, meaning conventional way, is that you would get an endoscopy. They make you sleepy, they put you out, they put a camera down your throat, they're aspirating juices from your small intestine and culturing it. You see why that might be a disadvantage. Pretty invasive for someone with bloating. Granted, we all know there should be screening. There's colonoscopy and endoscopies for screening purposes. But in a bloated patient in whom you're suspecting SIBO, there's got to be an easier way. You're not going to scope them. You're not going to do all this. There's a lot of problems here. It's invasive. Culture-based techniques don't allow for the growth of all organisms. Some of these are anaerobic. They may not grow. Contamination. Additionally, a scope can only reach so far. You can't get your way all the way to the distal small intestine, so you'd miss things. So this is kind of blatant. I mean, this is not the way to go. So we know this. This is why they developed breath testing. Now think how simple breath testing is, how much cheaper, how much easier and less invasive. So here's what happens. Many of you have used SIBO breath testing. I'm just going to put this out there. I don't mean to insult your intelligence. I'm just going to talk about it like we talk about it in general on the phone. What happens is Rob and Alex and Sam will give you a box. It's got a bunch of vacuum tubes in it. They're glass. And there's a mouthpiece. You puncture the top. And you give a baseline breath after fasting overnight. Then you drink a substance, sugary substance, lactulose. Drink it. As the lactulose travels through your small intestine, if there are bacteria present, they'll metabolize this. So you're going to give timed breath samples every 20 or 30 minutes as you're following the lactulose make its way through the small intestine. They can make hydrogen or methane. That gets absorbed through your intestine into your bloodstream, carried to the lungs, and it comes out in your breath. Kind of cool, right? So you see why this might be simpler than sticking a scope down there and poking around. So again, it's pretty non-invasive. Box comes to you, baseline, drink the lactulose, time to breath samples following it through that small intestine. Let's talk about the substances used for SIBO breath testing. Some people use lactulose. Some people use glucose. There's good and bad for both. Genova uses lactulose as a substrate, and we use it because it makes it all the way through the intestine without being absorbed, so it can go all the way through. Therefore, it's pretty good at picking up distal small intestine, and if you can consider that that's where the bacteria are coming from, you might be able to pick it up sooner. So lactulose is good in that regard. However, glucose is a little bit more sensitive, but glucose is very rapidly absorbed. So it's probably all getting absorbed really high up in the small intestine. So some people prefer glucose, but know that if you use a glucose SIBO test, you're probably going to miss the distal. I don't know if this might be a good place to talk about lactulose as far as what Genova does. In the United States, lactulose is included in the kit. Here in the UK, the rules are a little bit different. And so if you pick up a SIBO test kit, there'll be instructions regarding lactulose, and they're a little bit different than what we do in the United States. Oliver, you want to touch on that a second?
I didn't know I was being brought in then. We never rehearsed that bit. Okay, so lactulose. It's a strange one because this is the boring bit, so apologies for that. Lactulose, as you all know, is a medicinal product. Because of its very nature, that means it comes under the remit of the MHRA. Now, if we as a company, being Genova, decide to import lactulose into the country, which we would be effectively doing if we bought completed SIBO kits in, we would need what's termed a manufacturing license. If the MHR would be happy for us to import it, considering it's available locally anyway. Anybody that wants to distribute a medicinal product has to do it under license from the NHRA. We don't hold that license, simple as that. So I cannot provide, if you said to me, send me a SIBO test kit, I cannot send it to you because I do not hold a license to distribute medicinal products. In the same way that depending on your qualification, you should also question whether or not you should be receiving medicinal products from me and or giving them to patients. So that's why we don't provide it. The flip side being, in another twist of fate, it is commercially available at a pharmacy. So or Kamal's going to just basically deal it for everybody. So patients can go to the pharmacy and they can buy it, but I cannot give it to you because it's medicinal, and you should be sure that if you are giving a SIBO test kit to a patient containing a medicine, you have the appropriate license to do so as well. It's a very convoluted and difficult thing to get precise information on because the MHRA don't just have like a list of things you can and can't do. They're quite pedantic with certain things, and this is one. So I have made a decision not to provide it based on the fact I don't want to put anybody in an awkward position, yourselves or Genova Diagnostics. The other side being, with these types of licenses, should there be a product recall, which does happen from time to time, who then has to take control of the recall process? So if I've provided any one of you with 20 test kits containing a medicinal product that gets recalled, you would have to know where you have sent each of those products and what batch has gone where, so you could it be part of the recall process. So unfortunately, it's not very straightforward, hence my opening statement, this is the boring part, but it is available for a patient to walk into a pharmacy. So what we do provide is instructions that they can dispense it into one of these tubes, 15 milliliters required. There's the tube, which is graduated, and a pipette to do so, and then they can make their own mixture to carry on. Someone's going to have a question, I know it. It's not, I'm not going to get away that easily, I know that. Does that make sense? I knew it was going to be you as well. I'm ignoring that side of the room. Go on. I believe so. If you kind of Googled it, you can find pharmacies that do stock it, because some obviously sell it online, but I believe most pharmacies will stock it as an over-the-counter product. There must be another question than that, surely. Does it make sense, though? Okay. Any more questions come up, just shout. Oh, there you go. Yeah, it's easy. Tube's empty. Okay. No, lactulose is a liquid. It comes three. Yes. So they can buy a bottle of lactulose, which is 3.3 grams per 5 milliliter. They require 15 milliliters of that to be mixed into 240 milliliters of water. That will give them their required drink. So as Paddy was saying, they do a baseline sample, drink the drink immediately, and then they do the sampling over the next 2 to 3 hours, depending on what you desire. That, you're going to say that's the same thing? Okay. Yeah, well, it depends on you. So this kit we treat in the same way that we treat all of our kits. So if you said to me, can I send it directly to a patient? Sure, I'll do that for you. If you say, well, we have a clinic, we do lots of these, the patients come here to do it, we'd like them in stock here, that's fine. I just can't do it with a lactulose involved. I have. Apologies for anybody on the webinar, this doesn't make nearly as much sense for you lot. So, do we want a demo now on how this works?
Nice.
I knew it was happening at some point, don't worry.
Wow, that was a dramatic flair as well.
Did you enjoy that?
That was great.
One breathing device. It intentionally has a hole in it because we don't want to just fill it, we want the air to pass through it. What Paddy will get to later on is we have a control test that takes part in this. So people will simply breathe into the bag and it will inflate as such. And this little tube on the side, which does contain a needle, so don't put your finger in it, is a bit like a vacuum system. So once the bag is inflated, you simply, oh, we're what, my glamorous assistant. Thanks, Debbie. So you blow into the bag, you then literally push the tube straight into this holder, hold it, leave it in there for a couple of seconds, remove it. That's vacuumed, like any vacuum would be for blood collection. So the air comes from the bag into the tube. If you were to take your mouth off the actual breathing piece, if you like, and then put the tube in, you're going to get too much environmental air come in, which is where our control, we call it control test, where the control testing comes into place, which we'll get to in a moment. But it is that simple. We're going to do this again later, aren't we?
Boom.
Yeah, okay. But yes, so here's the kit. Thank you. Any more? Would the 6 or 8, depending on if to inflate it once or just throughout the whole test? 6 or 8, depending on a 2 or 3 hour test.
I'm about to show you that.
I'm taking all your glory here, aren't I?
No, that's great. I'm about to show you that.
As I said, I don't get allowed out much, so this is good as a backup. Uh, 7 to 10 days. Back to you.
Well,
I don't know, sorry.
Well, I guess there's the shipping part of it. So you have to ship it to the United States. We say a turnaround time on many of our tests, 7 to 10 days or 14 days or 21 days. Oftentimes it's sooner. I think the problem with getting it within 48 hours might be the shipping part of it. And then, it might give a little bit of an extra day there. So I don't know if they can promise it within 48 hours. Yeah. None of our tests are stat, this isn't a hospital, right? So it's really one of those things of they give you an average turnaround time based on how many kids come in the door and how many people work, and oftentimes they beat it. So probably the best I can do there.
The good news about us using our own laboratories is ultimately we have a direct hotline to the lab staff, if you like, and their supervisors.
That's right.
So we're lucky enough that there's certain team members in the United States who actually start early in the morning. A couple of military people that are out of bed at 4 o'clock in the morning, or for some reason, who knows why that works. But he's often in the office at 5, which is 10 a.m. our time. So actually we can go to them and say, can you do us a favor? We'd like you to pull one out the bag and push it through for us. And they will do their best to do it. What we'll never do is promise to do it within a certain amount of time, because things go wrong. If, the guys are very hot on their quality control. If something was to fail, we say, no, we have to rerun that again, then it takes longer. But if you need us to try and expedite it, we will do our best, but I can't promise anything. Yes, so if everyone didn't hear that, is the test time sensitive? So to some degree, yes, but not in we have to have this in our office in 12 hours kind of way. So if a patient decided Saturday's a good day for me, they can do it Saturday, they can ship it to me Monday, I'll get it Tuesday, that's fine. So no issues from that end. But if they hold on to 3 weeks, I might think about running it. You'd be surprised what people keep in their fridge for 3 weeks before sending it to us.
Very true.
You've all guessed it, well done.
All right, thank you very much, Oliver. Yeah, it's a little bit different than it is in the U.S. because it's actually included in the kits in the U.S., so a little bit different. Thank you. So again, like Oliver said, it comes with collection pack instructions, and he literally just walked through it. It's that simple. But as part of the collection instructions, it's important to note that there are certain things that are in the collection pack instructions to prevent getting a false positive or false negative, like fasting overnight, avoiding certain things. All of these, if you'll note, you have to worry about antibiotics. You don't want to be on antibiotics because you're going to kill off all the bacteria in a negative test, right? So you want to wait a certain amount of time for things to repopulate after antibiotics. Laxatives, stool softeners, things that will push things through and increase your transit time, right? So if you're on all these medications and things are moving through quickly, it's going to change how we interpret the test because lactulose and everything is just going to start moving through quicker. Yep, anything with magnesium, yes ma'am. We also limit your diet because if you eat something the morning of the test and it just starts to ferment, we're going to pick up those gases not related to lactulose, right? So you have to be careful. Gum, candy, which is interesting because some of these actually have some additives in them that can alter the test, that will start to be picked up by the test that isn't lactulose related. And then no sleeping or smoking or vigorous exercise, toothpaste, some of these other things can affect the reading of the test as well. So it's important, if you want a good test, the test is easy to do as you note, but really pay attention to those collection pack instructions. And yeah. Yeah, that's a good question. And so there are patients who are profoundly, and those are the patients that we want to do this test on, right? When we get to this slide, we'll talk about how there's a 2-hour SIBO test and there's a 3-hour SIBO test. The normal transit from your mouth, the end of your small intestine, they say is actually 90 minutes. So even 2-hour tests should surpass that and cover it. But in patients with constipation, that's why we have the 3-hour test to account for that. So we wouldn't recommend that they take anything to move their bowels the day of the test, but you might want to consider the 3-hour test to compensate for that. Great question. And when you look at your requisition and your collection pack, you'll see something that looks like this. This gives you the specific collection instructions, very similar to what Oliver just did, so it's fairly simple. But what we have here is you actually write your actual collection times because the instructions will say baseline sample. We want you to write down that time. Then we say drink your lactulose and then give us a sample 20 minutes after that. We want you to write down those exact times just so we can, in interpreting the test, make sure that we're all on the same page here because we don't want a patient taking 20 minutes to drink the lactulose and then like, oh, it was about a half hour later. We want to know the exact time so we can help interpret the test in light of that. It doesn't disqualify the test, but it helps us to interpret it properly. And if you see at the bottom here, one of our compadres, Dr. Stubbe, did a demonstration video for patients to watch right on the website if they don't know how to work this specific mouthpiece and the bottle. So if you're shipping it to a patient and they want to follow along on the website, we have a video for that as well. So what does this mean? We had a SIBO test for many, many years. In 2017, SIBO kind of became a real thing. People started to really understand that this was something they should really pay attention to. And I'm talking about gastroenterologists, the American College of Gastroenterology. They put together this consensus group because although in functional medicine and some of the other fringe doctors have been measuring this, Genova's been measuring this forever, there's no consensus around this. There are no guidelines around this. It's really just starting to become accepted in mainstream. And so in America, they put together this North American consensus group of all of these specialists from Canada, United States, Mexico, all these gastroenterologists to say, what's our official stance on this? And what came from that was this North American consensus paper. So they reached consensus across all lines about how are we testing for SIBO, how are we diagnosing SIBO, and what does this mean? And so what Genova did, first we said, praise God, they caught up to us, yay. Then we said, okay, now we really got to be in line with what's accepted. And so we updated our test to kind of follow the guidelines by the consensus paper. And it's available, it's a reference actually on every SIBO report. The reference is at the bottom from Rezier et al. On that exact paper if you want more information. It's on this slide as well. So as we said, we have a 3-hour test and a 2-hour test. Like I said, most people, a 2-hour test should be fine. However, think about those patients in whom you're ordering this. A lot of them are constipated. They may have lower transit times, which is why we also offer the 3-hour test. So again, baseline breath, and then it's like every 20 or 30 minutes based on whichever test you've ordered, and is outlined very specifically. And again, you might consider the 3-hour test in someone with slower transit. So here's what the test report looks like. At the top, you will see there's a graph of hydrogen and methane. The white open circles are hydrogen, the black closed circles are methane, and it's plotted based on the time it was collected. And then at the bottom, we have a chart. And in this chart, are the answer or the results for each of those readings, but we also put here the actual collection times because we want to know how closely did the patient follow that test. Not necessarily that it's a good or bad thing, but we want to be able to interpret this properly because as you'll see, the interpretation is somewhat time dependent, and we'll get into that on the next slide. But the other thing, what Oliver touched on, is that every sample that comes through Genova for the SIBO test has this carbon dioxide evaluation for quality control. So every sample is tested for room air carbon dioxide. If the sample is sufficient that it's not a problem, everything's collected properly, you'll see a nice pretty green check mark. If the sample needs to be rejected for whatever reason, you'll see a red X. And they'll allow up to 2 in the first 60 to 90 minutes before it really starts to alter the interpretation of the test, and they'll ask for a resubmittal. But if you see 1 or 2 X's there, it's not that big of a deal. We can still interpret the test. It's just going to be a little bit trickier. But just so that you know, Oliver pointed out there's a hole in that bag because we want that air to move through. We don't want to contaminate the next sample. But every single tube is checked for carbon dioxide to see if there's room air contamination. At the bottom left, you'll see the evaluation for hydrogen synthesized. At the bottom right, you'll see methane. And what I want to point out is here are all the readings. Here's all the time intervals. You'll see where it says evaluation for hydrogen. What we're looking for is a rise of greater than 20 parts per million from baseline by 90 minutes is what the North American consensus paper says is a positive diagnosis for hydrogen positive SIBO. So that means you take the baseline and then you go to 90 minutes and you look for the highest at 90 minutes. Which of these is the highest? So it's 63 minus 5, 58. That's high. With methane, it's different. It's just the highest level of methane anywhere in the test. Because what they found is that methane doesn't ordinarily rise and fall. You usually get this steady state of methane that kind of stays throughout the test. So what they tell us in the North American consensus paper is that greater than 10 is a positive methane test. But peer-reviewed literature, a preponderance of it, says that there's very significant clinical sequelae from a methane result of 2, 3, 4, 5, 6, 7. So even though the North American consensus paper doesn't call it positive, we put it in yellow when it's positive at all, just to kind of put that out there and say it still could be clinical significance. It's not to the level of being positive methane SIBO by the North American consensus paper. However, it's there. And if you have a patient who's symptomatic and or bloated or constipated, although we're not calling it positive, there's something here that may be treatable to see if you can help improve that patient's symptomatology. So this would be a methane positive test in that regard. Does that make sense? Yes, Nina. Mm-hmm. Great question. So she's asking about dietary influences, if there are methane producing things that people are eating. I would answer that this way. Number one, you would expect some of that to mainly be happening in the large intestine, not in the small intestine. And with the fast, the hope is that you've moved all of this into the large intestine that's not being picked up in the gases in the small intestine as you time it. Make sense? That's why the fast and the collection pack instructions are super important on this test, because there's a lot of other things that can interfere, to your point exactly. Great question, great question. Okay, so again, what we just said here is a rise of greater than 20 over baseline by 90 minutes is positive. So this cut point is widely seen throughout literature. So you'll see this. That being said, a lot of labs do things differently. We chose to go with what's the consensus of all the specialists that have really studied this. And that's why the test was upgraded. So we see this. In a symptomatic patient, you may consider treating a patient with a high hydrogen. Now, an important thing to note is that you may have a patient who's profoundly symptomatic, bloated, oh, terrible, you're like, this is SIBO, slam dunk, let's just get the breath test. You get the breath test, and there's no hydrogen anywhere in the test. Important to note is that anywhere from 8 to 27% of patients won't produce hydrogen gas. Because if part of their overgrowth in their small intestine are methanogenic bacteria, which means bacteria which produce methane, they gobble up hydrogen to make the methane. So a flat line in hydrogen in a symptomatic patient, you always have to put it together with a clinical picture. And someone who's profoundly symptomatic in a flatline hydrogen, you might say this could be hydrogen sulfide SIBO. And it starts to gobble up hydrogens everywhere it can to make hydrogen sulfide and to make those methanogens. This comes up a lot. We have patients who are profoundly symptomatic and they have a false negative. And so we always say, number one, you treat a patient, first and foremost. And 8 to 27% of patients have a falsely negative result because of methanogenic bacteria and the production of hydrogen sulfide, which always begs the question, why aren't you measuring hydrogen sulfide on this test? And the answer is that there's no commercially available way to measure hydrogen sulfide in the breath. There's a lot of research being done. Genova has been in a lot of talks with Quintron and trying to decide what's the most responsible way to do this. So it's there and hopefully on the horizon. But as it turns out, there's no commercially available kit to do that. So if you have a profoundly symptomatic patient and a flat hydrogen, all is not lost. You would really pay attention to number one, is their methane high? In which case, there you go. If not, could it be something else going on? We're going to get to that a little bit further. Yep. Correct. Correct. Methane will always be picked up. So if the methanogenic bacteria are gobbling up those hydrogens to make methane, you're going to have a methane positive test. Right. Mm-hmm. Right. You might, because remember that the stool test is a large intestine test. So it's a great point. And like I mentioned earlier, is that part of our clinical evidence development, there are a lot of patients who have actually done the GI effects and the SIBO test at the same time. Super interesting. So we're trying to find that clinical association because we do measure some methanogenic bacteria on the GI effects. And so our question is, can we stop there? If this is at a certain level, can we assume they're going to have SIBO or this is going to be a positive test? So that's kind of what's coming next, developing some of those scores to push this even further. So that's coming, but great question. And additionally, although we can't use the GI effects to diagnose SIBO, there are certain markers on the GI effects that make us highly suspicious, like a really high abundance, for example, the presence of Methanobrevibacter smithii, sometimes really high products of protein breakdown, sometimes really high fecal fats, because remember this blunts the microvilli in the small intestine and you can't reabsorb some of those nutrients. Sometimes we see a pancreatic elastase that's low because that blunting of the microvilli blocks the signaling back to the pancreas. So there's a lot of things on the GI effects that we find super interesting. We can't diagnose them, but it leads us here. The hope is the next step will be that. So that's a good question. So again, we're talking about methane. Whenever you have something greater than 10, this is going to be in red because that's what the North American consensus paper is telling us. That's slam dunk methane positive. But again, somewhere between 3 and 9, we're going to outline in yellow because there's enough papers out there that tell us methane's kind of important. There's a lot of symptomatic patients out there who will have a methane of 3. And we don't want to tell them this is negative because that could be very clinically significant for them. And therefore treating would be an important thing. So here's what we're talking about. People measure methane for a lot of different reasons. We say 3 to 7 is clinically significant because we know methane slows things down. It constipates people. So just the presence of having Methanobrevibacter smithii is kind of the point. Some people say just having Methanobrevibacter smithii is enough to treat this methane. We're saying maybe, but we're also saying that even lower measurements of methane are important because it slows transit. And what they found is that the severity of constipation directly correlates with the levels of methane. So even someone who's complaining of constipation with a methane of 3 or 4 might be worth treating that patient. Obesity, also very interesting correlations with methane and obesity in patients who are having a hard time losing weight. There's a lot of anecdotal things we hear on the phone of patients who had a hard time losing weight for a long time. They did a SIBO test, treated methane positivity and lost weight. It's really interesting anecdotal, but there is some literature out there as well. So we talked about this. If this here's an X. So if the carbon dioxide is found, we're going to reject that sample. Again, when you're interpreting the test, we know that the North American consensus paper says that by 90 minutes. So it wouldn't really affect our interpretation of this test. But if you have a couple of those X's early in the test, it will. So they may reject and ask for a recollection. Again, this is where we're showing you that on the requisition, we'd like you to put the actual collection times for many reasons. We kind of just talked about this. So you kind of look at their actual times. They may not always correlate with 20 minutes. They may have waited 30 minutes, but that's important to know. We want to know those specific times when we interpret it for you. So what do? Someone has a positive SIBO test. Most people, you have three things you want to do. Treat them with something antimicrobial. You want to treat that overgrowth, whether that's prescriptive or a pharmaceutical or some kind of herbal. Provide nutritional support, because remember, all the nutrients that are reabsorbed in the small intestine that may or may not have problems, you want to always support nutritionally. And then the biggest point is always go a little bit further. Why did your patient get SIBO? Because unless you treat and address that underlying cause, odds are this is going to come back. You'll see here that 44% of people relapse. And the reason these patients relapse is because we're not taking it that next level. We're not looking for the cause. So that's important. So what do people use? Rifaximin is kind of the mainstay of treatment here. In patients who have hydrogen-only SIBO, often the single agent's enough. Rifaximin. Patients who have hydrogen and methane, they often use two agents, usually rifaximin and neomycin. There's a lot of botanicals that have a lot of good research. I will tell you that there's some really good papers out there. There's some really good websites. Let's see if it's on my next slide here. There's a website that we often send clinicians to called SIBOinfo.com. It's run by Dr. Alison Siebecker, who's kind of one of the gurus in SIBO. She's been doing this for a very, very long time. She has a website we often send clinicians to because it's full, jam-packed with literature associations, treatment protocols, specific treatment protocols, like this herb for this many days, 4 times a day, this medication, this amount. She lists it with literature references, and she also kind of outlines what has helped her patients in her practice. So it's a great resource, and we often send people there. But again, we talked about the specific way you need to support them nutritionally, right? Oftentimes, these patients have low fat-soluble vitamins because things weren't getting reabsorbed in the small intestine. There's a lot of deficiencies you need to readdress. And there's also several diets that have been used, low FODMAPs, things that are fermentable that cause a lot of symptoms in patients. So while you're treating all of these and looking for the underlying causes, some dietary changes may help symptomatically as well. So back to addressing the cause. Some of them are pretty simple, right? Some of them are very simple, like, oh, my patient was on oxycodone for a back injury, or my patient's on a certain medication, stop the proton pump inhibitors. A lot of things that are simple, but what about the migrating motor complex? So you always have to think about what are the ways you can improve that. Someone's getting older and this is slowing down. What are some things you can do to improve that? Prokinetic agents. Some people use low-dose erythromycin. There's some natural agents that can help to move things forward, because without treating that underlying migrating motor complex, SIBO is going to relapse and recur, and your patients aren't going to be very happy about that. But again, the other things people do are meal spacing every 4 to 5 hours, because this migrating motor complex takes some time to sweep things through. So if you space your meals, you may be able to help support that as well. Again, we're going to go back. When you think about the causes, we had that whole slide on causes. So run through that list each time you're treating SIBO to make sure you're addressing the underlying cause. Stop the medications, acid blocking meds, anything that slows transit. Treat your hypothyroidism. But then again, what's causing the hypothyroidism? Is it an autoimmune problem? Do they have leaky gut? Is there something else? Always go deeper. Always ask why and take it that next step. Hypochlorhydria. You can think about betaine HCl, bitters. But again, always go back to that next step. What's causing the hypochlorhydria, right? Is it elderly patients? You always have to take it that next step. Make sure you're looking for every cause. If not, this is going to keep coming back. And it's a high relapse rate for a reason, because we're not taking it that next step. Obviously, someone's had their ileocecal valve out. There's not much you're going to do there other than optimize everything. Go, go, go. What do you want to do? What? What?
How can you help?
Oh, what can you do for the ileocecal valve? Oh my. Go, go, go. What? Tell me. Yeah.
Well, mechanically, you can work on the ileocecal valve to try to implement,
Spoken
the
like an
neurological
osteopath.
system.
That's my girl.
Yeah. So to get the impaired nervous system to start again, so then you begin to get the peristaltic motion and the reflux between the ileocecal valve, so large intestine and small intestine, hopefully will stop. So that potentially could be a very good way to treat.
So visit your local osteopath.
Yeah.
Thank you. Thank you.
Who knows about visceral osteopathy?
That's right. So what do you do? When do you retest? Well, it's interesting. There's a lot of things that you think about. So the consensus paper says you should wait 4 weeks after antibiotics before retesting. However, some papers are now saying if you have someone on antimicrobial therapy, it might be worth retesting immediately to see if things are coming down, to see if your treatment's effective. So it can go either way. The recommendations, according to the North American consensus paper, is 4 weeks. Kind of up to you. Let's run through a case here real quick. 34-year-old female with bloating and alternating diarrhea with constipation. She traveled to Central America 9 months ago and caught a GI bug, which is often the case. Once you grossly alter the microbial community, SIBO seems to take hold there. There are certain foods that she finds herself eating more to try to control symptoms. And you often see patients do that. I stopped eating that because it just makes me feel so bad. And it could be something that vague, but always think SIBO in those patients. So now her daily life is being affected. So the young 34-year-old female. So here's what the tests look like. Remember we talked about the consensus paper saying greater than 20 of hydrogen above baseline by 90 minutes. Here we are. Here's 90 minutes. So that's 63 minus 5 is 58. That's super high. Additionally, her methane. So you'll see, like we talked earlier, methane often doesn't peak and come back down. It's more of like a steady grind. And so you see that often with methane, and that's what we're seeing here. It's not negative. It's 7. And so it kind of speaks to this patient who's had alternating constipation and diarrhea, because oftentimes we said methane slows things down. Hydrogen is sometimes associated with increasing transit, but not always. But methane is usually a slower down. So because that patient had a mixed IBS type picture, the clinician chose to use 2 different antimicrobials. So again, if you go to a place like SIBOinfo.com, Dr. Seibecker goes into specifics on Candibactin AR and VR and Allermed, which is a garlic product, just to kind of cover it from both ends. So depending on what your prescribing rights are, depending on the symptoms of the patient, there are a lot of options out there for you. Low FODMAPs diet, which we talked about, decrease the fermentable amount of carbohydrates for symptomatic relief. And again, meal spacing. After 2 months, the patient got better. However, they continued. Now, important, the goal isn't to continue low FODMAP diets, since they are important. We need all kinds of fermentable things to make short chain fatty acids in the large intestine. So if possible, this is why we say you don't want to keep a patient on a restricted diet when there's something you can reverse underneath. What's the cause for that SIBO? Let's go there. Case example number 2. 66-year-old male with bloating and excessive belching and flatulence, severe constipation. And again, 2 bowel movements per week, which he considers a normal pattern for him, which is why I bring up that concept of you really need to be specific when you talk to patients, because someone like this might say, oh, it's normal. It's normal for him. Clearly not normal. And look what comes along with that: obese, hypertension, hypothyroid, diabetes. Add that, some oxycodone, which will further slow things down. Standard American diet, which we call SAD. Here's his test. This is not shocking to anyone based on what I just described, right? So The hydrogen is not bad. By 90 minutes, 13, subtract from baseline, that's 6. That's underwhelming, but look at all this methane. Look at all that methane. That's a lot. So of course, this is why he's constipated. It's an association with obesity. He also takes oxycodone. I mean, there's a lot here. But for many years, these were the IBS constipated patients. Nobody even paid attention to something like SIBO, but look where we are. It's very exciting. So what do? The clinician chose to treat methane-producing organisms with rifaximin plus neomycin. Those can be a little bit trickier. I will say people often double cover when there's methane present because it can be trickier. These things are fairly straightforward. Prokinetic was described, things that kind of help push things forward. Magnesium, again. They switched to armor thyroid, and I'm not sure the specific reason around this other than thinking maybe someone would respond to a different medication that's more bioidentical. Fiber was avoided. This is interesting. This comes up a lot on the GI effects, and I want to touch on this for a second. When we spoke earlier to say, you can't diagnose SIBO using the GI effects. There are a lot of things that we hear on the phone that make us think SIBO, and we touched on them. Methanobrevibacter smithii being positive, really high abundance, really high products of protein breakdown, high fecal fats, sometimes the pancreatic elastase. The other thing that always sticks in my craw is that when I get to the bottom of that dig page, and I start talking about short chain fatty acids, and we talk about fiber and how important fiber is to make its way to the large intestine to be fermented, because short chain fatty acids are super important. And if I hear a clinician say, oh, she doesn't eat fiber, it makes her feel terrible, ding, 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 like that's a huge flag. That's something that makes me think SIBO right away, even if everything else is normal. So fiber is important for constipation, but in a SIBO patient, they won't tolerate that. That's going to make them feel miserable. So again, you have to look long-term. You're going to treat SIBO with antimicrobials, but unless you go deeper and you treat some of those long-term issues, we're going to be right back where we started. And again, it comes down to a high recurrence rate. Unless you get someone off of the pain medication, you start to change their diet, you start to move things forward. So always go there. Additionally, a GI effects comprehensive was ordered. So again, we talked about this, all the other abnormalities associated with SIBO. You really want to make sure that they're improving and being addressed as well. So we talked about this. I touched on this briefly. What's the flatline test mean? It can mean a lot of things. People get this test back that's completely normal, and that looks abnormal to them because they had a high suspicion. So what are the things you think about? Number one, maybe it's negative. Maybe it's not SIBO at all. So never be so convinced in your pretest probability to ever question it, because it could just be a negative. And you might consider other testing. It might also suggest hydrogen sulfide, which is what I was talking about earlier. There's another gas that can be produced that gobbles up all those hydrogens, and that's hydrogen sulfide. And like I said, there's no commercially available way to test this now. Some people are developing it. Genova's working on this as well. But what is often described as a really foul-smelling flatulence of rotten eggs. So if you have a completely flatline test and symptoms that you're convinced are SIBO and any of this fits, you might consider treating. The other problem is maybe the patient didn't follow the collection pack instructions. So there's a lot that can go on as far as puncturing the top of the tube, breathing into it. Sometimes a lot of things happen with patients, which is why we have that video online to help the patients follow through. And then sometimes clinicians had patients on antibiotics and they didn't wait the full 4 weeks. With that, we talked about the GI effects as being something other to consider. We talked about all the reasons to order SIBO testing, but look how much these overlap with other GI complaints, right? We talked about that earlier. So think about the GI effects, because some of their symptoms might actually be a parasite, which you're not going to pick up on SIBO. So never be overly married to one diagnosis. If it's negative, you can accept the negative and consider another test. You might also think food antibody panel. Some of those symptoms are also vague. You might think about that. Celiac and gluten, also super vague. We talked about this as well through the test. This is a very common question we get here at Genova. And again, we don't say that it's diagnostic, but it sure does make you suspicious when you see these markers abnormal on the GI effects. The other thing to think about is a NutriVal. Think of all those nutrients that may have been malabsorbed. So once you've cleared out someone's GI effects and you've treated them for SIBO, you might want to think about a NutriVal because it's the next step to help replete some of those nutrients that may have been lost and malabsorbed. I know this is kind of end of the day, and you're all fairly familiar with SIBO, so there may not be as many questions. Oh, sorry.
Hi. You said in the beginning that neuromuscular diseases can affect or can contribute to SIBO. Could statins contribute to SIBO then?
Great question. I would say I don't know that there's a direct cause effect. I haven't seen that in literature. I haven't directly looked that up. But in my mind, I'm trying to find the connection of statins and mitochondrial dysfunction. Yeah.
When people stop taking statins by their own choice, the reason is muscular problems.
Right.
So that's why I was wondering whether that might also affect.
And I think it's more on the basis of a side effect from muscle pain and probably more mitochondrial dysfunction. So I think it's far more indirect. Yeah. Still probably there. Yep. Far more indirect, but still probably there. You had a question? I'm sorry.
This doesn't, two things.
Yeah.
This doesn't identify which small growth bacteria is there. It's just telling you that these are methane producing or these are hydrogen producing. And then you might prescribe them antimicrobials. So that could potentially lead to dysbiosis, right? Maybe.
It could, however, so there's if there's a dysbiosis in the large intestine, we're not throwing a bunch of antibiotics there. What's happening is those bacteria are making their way up in the small intestine. So the antimicrobials are to kind of knock the population back, and then you have to rebalance that microbiome. However, the dysbiosis that comes from an antimicrobial is far less of a concern than what's the underlying cause. There's a cause, right? So I see the point. I just think there's a bigger fish to fry. Additionally, there are some clinicians who try not to treat SIBO with antimicrobials at all. They'll do some herbal things. They'll work on meal spacing. They'll put them on some of these diets, like an elemental diet, which is horrific and difficult to do, but some people would to avoid antibiotics. And it's really just starving the bacteria at its most basic. So some people try to avoid antimicrobials. I would argue that you need to make the patient symptomatically better without making them mad at you, and treat an underlying cause, and then that dysbiosis you can work with.
This lactulose business reminds me of the old test Genova used to do on intestinal permeability a long time back.
Yeah, we still do intestinal permeability. We still do intestinal permeability.
Not with lactulose.
Oh, not yours? Oh, you don't do it here. We do it in the United States. Yeah. You guys are, yes, we offer that. Go ahead.
Oh, sorry. With patients that have got colon cancer that are actively going through chemotherapy and have had a stoma fitted, that seems to be setting them up for a fall to then get SIBO. Is there anything that you would suggest to protect them, to minimize that kind of potential for getting SIBO?
Such a good question. Yeah, I would say it really comes down to avoiding proton pump inhibitors if possible.
Yeah.
Make sure that the migrating motor complex is optimized. Things that are prokinetic may help.
Yeah.
Clearly with colon cancer, you want to make sure they're not immunodeficient. These are the things that would kind of help to prevent some SIBO. That's a tricky one. That's a very tricky one.
Would you automatically suggest that they go on a FODMAP diet?
It would be symptomatic. I think it would depend on their symptoms. If they were symptomatic, you might start there.
Okay.
Yeah.
Thank you.
Yeah.
No hands.
Sure. Thank you. Thanks for coming, everyone. I'm amazed that all these people came to hear this. That's really, really surprising. Thank you very much. Thank you for your time today.